All right, welcome back, everybody, and good evening. I'd like to welcome any new participants we have joining us tonight, as well as welcoming back any returning participants. Before I introduce myself, I'd like to bring your attention to the poll question. It's about to be displayed on your screen. If you could just take a moment and answer that really quick while I continue telling you about tonight's presentation and about the American Academy of Developmental Medicine and Dentistry. So my name is Michael Tarr. I am a second-year medical student at New York Medical College, and I am the AADMD Virtual Grand Rounds Facilitator. So the AADMD Virtual Grand Rounds seeks to create a space for mentorship and exchange of knowledge and experience between seasoned IDD providers, entry-level clinicians, and future healthcare providers in training. So the purpose of the Grand Rounds session is to expand and strengthen the IDD healthcare workforce across a spectrum of experience levels. I'm going to close this poll and give you another one. When we only have 3 polls, and when they're done, I'll display the results. Here's another one. In what stage of your career are you in? So at the end of the session, and actually during the session, I will post a link to a quick survey we've made into the chat box. Whenever you have the chance, if you could really try to fill out that survey, the feedback helps us make changes to the virtual Grand Rounds and make any additions that you find are important, but it also gives you a chance to let us know what you think about it, and if anyone is interested in participating or presenting themselves in the future, it's another place where you can let us know that. That being said, I'm going to close this poll and open the final one. So if you would like to view our previous Virtual Grand Rounds presentations with the accompanying lecture slides, we're working on creating a virtual library that you will be able to access from the AADMD website. Tonight's lecture or presentation will be included in that, and if you registered for tonight's presentation, you should have also received an email a few hours ago with the slides for tonight's presentation in it. So if you'd like to open that up and follow along with us, please feel free to do so. In addition, we're working on becoming CE certified, so then in the future you'll also be able to get credits for participating in the virtual Grand Rounds. All right, let me close this last poll. Before I share the results of the poll, I'm going to introduce our presenter for tonight. So I'd like to introduce Ms. Marissa Brown. Marissa is a research instructor in Georgetown University Center for Child and Human Development, University Center for Excellence in Developmental Disabilities in Washington, D.C. She has been associated with Georgetown University for the past 33 years, serving in many capacities. She is an advanced nurse practitioner specializing in the healthcare of individuals with developmental disabilities and has over 30 years of experience in this specialty. For the past 10 years, she has directed the DC Developmental Disabilities Health Initiative, an effort aimed at improving healthcare quality and access for adults with intellectual disabilities. Ms. Brown has served on numerous task forces and advisory groups at the local and state level related to children and adults with developmental disabilities. As the parent of a young adult with autism spectrum disorder, she is particularly interested in advocacy for services to support the community, integration, and independence. So I'm just going to go through the poll responses real quick, and then I'll hand this off to Marissa. So for our first poll, we can see that the question is which profession or role do you represent? So tonight we have joining us 10% of the participants work in administration, 7% are students, 24% work in medicine, 3% work in dentistry, and 55% represent the other category. Second poll, in what stage of your career are you in? We have 8% of participants are the pre-health professional training, 15% are health professional training, 0% are in their residencies, 65% are currently practicing, and 12% are retired from practice. Finally, our last poll. What do you hope to gain from this webinar? We have 21% of participants saying that look forward to learning foundational healthcare concepts for individuals with intellectual and developmental disabilities. 0% said networking. 45% said gain interprofessional perspectives on healthcare for individuals with intellectual and developmental disabilities. 31% said gain pearls from complex and challenging clinical cases, and 3% said CE credits. All right, and with that being said, one more thing. During the presentation, if you have any questions, please use the question application of the software to ask them. At the end of the presentation, we'll take about 10 minutes to answer any questions you may have or clarify anything that may have been a little unclear or confusing. And with that, I'll give the floor to Marissa Brown.
Thank you very much for that nice introduction, Michael, and thank you to the AADMD for all that they do to advance our better understanding about the needs of people with developmental disabilities. Tonight we're going to be taking a look at a set of issues related to end-of-life decision-making. The topic of end-of-life decision-making is getting a lot more attention with the Affordable Care Act, some changes that are anticipated in Medicare coverage. And yet, for people with developmental disabilities, many times people themselves who experience disabilities are really quite frightened about what this could mean. People with disabilities, not only in the past, but even today, continue to be exposed to sometimes some societal devaluing of their life and looking at what is their functionality, what is their contribution to society. And so they're very much afraid of end-of-life discussions are going to somehow become very pro forma for them. So I do hope that at the end, when we have discussion, there certainly may be some issues of controversy that are brought up tonight. Hopefully we'll be helping to set a stage, and my goal is to help make more people comfortable in having discussions about end of life. So we're going to get back to Mary John's case later in the presentation, but we're looking at someone who had a stroke, who her physicians, the hospitalists, are anticipating from the studies that they've conducted that she's probably not likely to recover her previous functioning. They're talking with her guardian. Mary had been deemed incapacitated. She was not able to make her own decisions, and a guardian had been appointed. This guardian has known her for 4 years. She does require extensive supports for all aspects of daily living, and she's never been able to communicate any kind of end-of-life decision-making. She was placed on a ventilator, and a week later she remains on the ventilator with no progress in her weaning, and now requires a gastric tube for her nutrition. The staff from the residence where she lives have seen people like Mary bounce back before, and they think, and they're telling the guardian, that she just needs more time to recover. So we'll come back to Mary in a little bit. Back in 2008, the U.S. Department of Health and Human Services convened a study to look at the advanced care planning needs of people with intellectual disabilities. And even though that was now 7 years ago, probably not much has changed. They cited then that there's a need for advanced care planning directives. Only a tiny fraction of people actually have completed directives. End-of-life care issues are seldom raised, and there are a lot of barriers with making changes in this area. Now, one could argue that this may not be very different than what we see in the general population. In the general population, there are quite a bit of cultural variabilities as to whether people want to discuss end-of-life planning, at what point do you talk about it, etc. I think it's interesting. Now, this is some data from the National Vital Statistics System for the U.S. that does look at where people are dying, and they do break it down into people who were under 65 years of age or over 65 years of age. And you can see for both populations, more and more people are dying in their home. And this certainly has a lot of implications for people with developmental disabilities who, number one, we are seeing increasingly that those young men and women, even after turning 22, are more likely to be living in their family home. And then for those people with developmental disabilities who do live in some type of supported living environment, in an apartment with a few roommates, or in a group home with 24-hour maximum support, again, that is their home. And I know here in Washington, D.C., over the course of the 10 years, we have seen more and more providers able to work collaboratively with hospice when, when it is time for someone to go into hospice services. I want to spend just a couple of minutes talking about some of the basis of the work that I'm going to be sharing tonight. Is from a small research study that I conducted in collaboration with people from our College of Nursing and clinical ethicists. And we developed a small research study that looked at the decision-making of guardians. And out of a total number of 100 guardians that serve people with developmental disabilities here in the District of Columbia, we did get 20 to respond to a pretty intensive research tool. And from that, we worked with the team, including people with developmental disabilities and other advocates, and helped to develop some interactive decision-making guides that we have really found to be quite useful in our consultation around end-of-life decision-making. And I guess it's not surprising to see that the majority of the respondents do recognize that these decisions around end-of-life certainly do have a moderate level of complexity to them. But the majority of them are describing that this process, complex as it may be, is not typically giving them moral distress, which hopefully is a good sign. We didn't go into that any more deeply. On one hand, you could think if a guardian is very experienced, if they know the person on whose behalf they're making the decisions, you can imagine that perhaps they don't have any distress in coming to some decisions related to end of life. The top 3 variables that people reported that informed their decisions were cause for some joy in terms of feeling confident that they're making good decisions. They do look at as compared to baseline, which for people with disabilities, that's really important. Looking at their functional abilities, and then the likelihood of recovery, or has there been a very rapid rate of decline. But the majority are reporting that they're either not very confident or somewhat confident for almost all of the decisions. And in the District of Columbia, because there is a long-standing lawsuit, we did ask a question as to whether they were concerned about legal consequences, and luckily only a small minority would not consider any kind of legal consequences based on their decision-making, which we saw as good. Today, certainly, and this could be a whole nother virtual grand round about self-determination and supported decision-making. We're really, hopefully in the future, we're going to see less guardianship occurring. In the past, certainly in the past even 20 years, there's some jurisdictions that pretty automatically see, oh, a person has an intellectual disability, family requests guardianship, they're probably going to get it. And a lot of times even school personnel and healthcare personnel are not as informed as they should be about the legal issues in their own state. These are state issues. And so sometimes they may even be teachers or physicians may even be recommending to parents, oh, you're going to need a guardian because only a guardian can make this decision. So the field is really moving to helping people to better understand shared decision making. However, there will always be a small group of people who will never have had capacity due to the severity of their intellectual disability, or anyone could lose their capacity to make decisions and may have to have a guardian appointed if there was no one else in their life, a family member or close friend who could do that. But it's interesting to see that last year the National Guardianship Association did issue a statement that really does emphasize here the importance of making sure that even when someone has a guardian, they need to participate to the maximum extent possible in the decision-making process. A colleague of mine, Erin Levitin, with the DC Department on Disability Services, put forth this visual of decision-making supports. And when we think about it in our everyday life, there are very few decisions we may make by ourselves. Some of that depends on our personality. But whether you want someone's opinion on what kind of jacket you should buy, to what kind of vacation you go on, to do I go ahead with chemotherapy or open heart surgery, again, we're often relying on people who are close to us to help us make decisions. And we certainly, when we're talking about people with developmental disabilities, we do need to look at their strengths, at their ability to communicate. How do we understand what are any limitations that they may have about understanding? Is there technology that can be used that will help assist a person in making some of their own decisions? And not just in healthcare. There's an example here of now with direct deposit and auto bill pay, someone with having that set up for them may be able to independently, hit a button on their computer and pay their own bills. With the emphasis of people participating and being part of their community, the importance of that long range is that they're going to develop peer supports. They may develop relationships with members of the clergy. They may hopefully will have a medical home so that the people that are surrounding them, if there is a really important medical decision that has to be made, are going to be familiar with them. Obviously, this is in an ideal situation, and sometimes with the mobility of society today, any of us could be quite vulnerable in any of these areas. And so there may have to be sometimes some eligibility specific type of decision maker, alternate decision maker, whether it's a guardian. Some people in their Social Security payments, their Social Security disability insurance, are assigned a representative payee because they have not been able to really make good decisions around how they spend that money. So there really is a complex set of circumstances that need to be understood. But when we think back on Mary John's coming into the hospital diagnosed with a stroke, we can bet that the healthcare personnel taking care of her in the emergency department and in the intensive care unit probably have no idea about what kind of supports Mary has. It really is something that does take a little bit of time to get that information. But I think one of the things that I hope to emphasize tonight is that no matter what setting you're working in healthcare, to know how to tap into more information about an individual is really important. The National Guardianship Association also does again have some guidelines around the need for informed consent. Here in the District of Columbia, the idea of substituted judgment is the standard. In other words, the decisions the guardian makes should be decisions that they expect the person would have made if they were making them on their own. If the guardian does not understand or have no way of knowing what the person would have done on their own, then there is the standard called the best interest standard. And of course, best interest standards, I think, can really be quite fraught. For some people, a medical person may have, and let's say a nurse or physician working in an intensive care unit who may have seen a lot of futile care administered to people over the course of their professional life, may be kind of quick on the trigger around do not resuscitate orders, versus someone else who says, well, this is the first time this person has been hospitalized with a serious problem. Why would I want a do not resuscitate order for this person? So while I think the law and attorneys may have a kind of very clear-cut understanding of best interest, I think in reality, best interest is a very culturally laden, value-laden concept. When we are working with guardians, there are some responsibilities that the guardian has to learn as much as possible about that person using the person's values and beliefs, not the guardian's personal values and beliefs. And again, making decisions that, whenever possible, would reflect what the person would have decided if he or she was capable of making that decision. And there certainly are times where it is both legally and ethically justifiable to consent to withholding treatment. But I was just consulting with a service coordinator today in a case where a woman has become ventilator dependent, but her family is still waiting for her to be able to be off the ventilator and are looking at, well, if the nursing home was doing everything they should be doing, she would be getting better. And so we conferred and set up and are going to work with the staff at the nursing home so that they are really more clearly articulating what they expect the person's prognosis to be. And sometimes coming to these issues, coming to a decision about stopping aggressive medical treatment are things that people do need some time to process and to be able to come to a decision. So that the conversation at every opportunity is so important. But certainly the standard of practice from the National Guardian Association is that in all cases there should be a presumption in favor of the continued treatment in case there was any kind of indecision. And again, I think this is where those of us who have worked with people with disabilities, our family members who maybe have a better understanding of the culture of disability, of the concerns of people with disabilities, there does need to be some strong advocacy in some cases, because we have had documented cases all over the country where people with disabilities have been refused surgery, refused certain treatments, because again, really the presumption was made, well, they couldn't possibly benefit from this treatment. The treatment would be too difficult for them to withstand without even in some instances, trying the treatment to see how the person does. So this is an area that I think we do have to be quite careful about and really have those good conversations with our colleagues in the medical profession who may not come into contact as frequently with people with disabilities. Certainly, I had mentioned earlier that culture plays such a large role. We could spend a very long time talking about this topic. What is the person's attitudes of illness? Is it something that is fatalistic? Are there people who expect that pain and suffering is part of life and this is what people should do? We actually had a member from a religious group interpret that pain was a responsibility for this person. The problem was that person did not practice the religion that her family had practiced. And so was that really an accurate kind of attribute to put to that person who has never embraced that belief system. Death in dying is death something that has been shielded from someone? A lot of times the support staff around a person with a disability say, well, we can't talk about death because it's going to make Mary sad. Well, yes, thinking about death, being told that you have an illness that is not going to get better, it is sad and would not be inappropriate for someone to cry or to have some distress over. And so, simply having a goal of we don't want someone to cry or to be sad is not giving them, again, that ability to be participating in some of their own decision making. Quality of life, we're going to talk about that a little bit more later in the program. What is the societal role for a person? We have, again, sometimes family members I just gave you the example of the person who is ventilator dependent, who the family is just having a really hard time, recognizing that. And then sometimes we have families who don't want their son or daughter with a disability to have any kind of discomfort, and so they may make some decisions that seem premature, that may not be seen as in the person's best interest. Do we know enough about the person's funeral and burial preferences? It's hard to have preferences about what you would like your funeral to be if you've never attended a funeral. So with all of the emphasis in the last 40 years around community inclusion, hopefully people with disabilities are living full and rich lives and are being part of lots of discussion and experiences that certainly enrich their life and help them to have a better decision-making capacity. And I always want to emphasize to people that when we talk about end-of-life planning, it's about the living part. This is really the time when I get called in for a consultation, if someone has had a major change in their health condition, maybe they have several chronic illnesses, the hospitalizations are starting to become more frequent with less time in between them. This is the time to really understand, what are the favorite activities of this person? Who are their favorite people that they want to spend time with? A couple of years ago, I spent some time with a man and his brother, and because of the man's illness with cancer, he had stopped attending his day program, and no one had ever thought to have people from the day program come and visit him. His brother did enjoy watching football games on Sunday, and I advised the brother, just do that as often as you can. Are there vacation plans coming up? Well, maybe we need to move the vacation up because maybe we can anticipate that their cardiac disease may really get in the way. So, can we do the beach vacation in May versus waiting till August? Really look at their dietary orders, and is this a time where the diet can be liberalized? Obviously, we know the benefits of various diet modalities in promoting heart health, etc., kidney health, but when a person has kind of crossed over into a time period where they may have expecting months to live, certainly once they're in hospice, it's definitely the time to liberalize the diet to something that they really like, and even if adding the salt or adding more sugar may be detrimental in the long term. Frankly, it may not matter at that point. And then our last point here is, what do we really understand about how the person shows pain and discomfort? This is certainly something that a person's family members or their support team needs to be able to convey to the medical personnel during a hospitalization, because it can be so important for the hospital staff to be able to understand and recognize and treat pain. Certainly, very important to the quality of life. The next 3 slides, I think, are very helpful to understand and not just for the layperson, but I think sometimes even those of us in the helping health professions to kind of think of people along a trajectory. Certainly a lot of studies have substantiated that we are not very good at predicting how long a person has to live until it's at the very, very end of their life. But we certainly know that with some types of cancer, quite virulent cancers, there's probably a very short period of evident decline where, you know, it seems like a few months ago the person was pretty healthy, enjoying all their typical activities, and now within a 6-month period of time, they're quite debilitated. Some cancers, however, can have more of a long-term type of limitation with intermittent exacerbations. This is also typical of people with organ system failure, and so this is the person that you see time to time. They may enter into the hospital with an overwhelming infection. They may be in the intensive care unit. They may be on ventilatory support, but then they do recover. And then, again, more typically, that trajectory involves the more frequent hospitalizations, needing more aggressive therapy. This is certainly a time early on into this process to be trying to talk with people about end-of-life planning. And then for people of advanced age, people who experience dementia, a more prolonged dwindling where you see a loss of maybe mobility, definitely you see the loss of appetite, weight loss, kind of a loss of interest in a lot of things. And this is, again, sometimes you would think that knowing that a person of advanced age, that we would be better at planning some of the end-of-life understanding, but it doesn't necessarily mean that. A lot of times people are just trying to, I think, you know, again, avoid that conversation. Sorry, I didn't advance the slides there. We really do need a good multidisciplinary, proactive discussion, whether it is with the hospital staff, whether it's including people from the residents, the group home, members of the clergy, if the clergy is part of a person's life. We really do need good communication, and we need, and people like you who are, you know, on a call like this tonight, to be the ones to kind of step forward. There's you know, not any type of formal real preparation for this. It's really having, you know, the interest and really wanting, I know for me personally, it's around really helping to promote a good quality of life. The concept of futility, I think, is something that may be well understood in the field of medicine, but I think the average layperson, and maybe this is because of the, you know, how the media helps to portray what happens in emergency departments and people surviving all kinds of surgeries, you know, probably reality TV shows, who knows. But that there does come a point, we know, that the person's quality of life, because of the need for repeated aggressive medical interventions, that the person begins to benefit less and less all the time, and their quality of life becomes poorer. You know, the central question is the person's life worth living? But we have to be careful here that the assessments around this be objective and that they are not biased around some kind of implicit bias around disability. So my colleagues at the School of Nursing here at Georgetown, we put together this kind of a framework of, we wanted the idea of a toolkit, if you will, to help people think about end-of-life decision-making. And while we initially developed these tools to help us think about people with very significant intellectual disabilities who may not have ever been able to make any comments or indications about what they would like. I do find this increasingly helpful, even with someone who is very verbal and very independent in making their decisions. So we have a set of ethical case scenarios. We have a guided interview that really helps to crystallize some good questions at the medical case conference. And then we have a tool to help look at quality of life. Excuse me. In the ethics workup developed by Dr. Carol Taylor, she brings us through a set of questions so that we are guided about what are the facts, what is the issue at hand that the decision maker is being asked, how do we frame that issue, are there alternative courses to be weighed, and then sometimes some decisions that are made, you know, you make a decision to have a do not resuscitate order, and then that was done in the hospital. The person never did need resuscitation in the hospital, and now they're coming home. Well, now what? How are things going? We had a gentleman not too long ago that we had several independent consultations from 2 different university medical centers. They said this person had a severe paralysis of their intestines. There was nothing that could be done, was not a surgical candidate, etc. And the person went into hospice, and he was reevaluated in a couple of months. A third opinion was sought, and they removed this man's gallbladder, and he is at home, pretty much enjoying his life the way he had before. So there always has to be it's very important to critique some of these decisions, and to, you're never painted in a corner. You can always, relook and re-examine, the decisions that were made. So if we go back to Mary Johns, we do have a number of facts here I'll add. Mary is 50 years old. She has always had a profound level of intellectual disability and adaptive skills. She has co-occurring disabilities of cerebral palsy and requires a custom-molded wheelchair for mobility and 24-hour supports for all aspects of her life. She'd been institutionalized at an early age, and she really doesn't have any family connections at this time, but does have a court-appointed guardian who's known her for about 4 years. The guardian has been participating in all the interdisciplinary meetings. He notices that the staff at the residence seems to turn over quite a bit, but the guardian remains diligent in communicating with the staff so that he's well informed of Mary's needs. The guardian gets a call from the hospital, and it's the medical resident informing him that Mary has had a significant cerebrovascular accident. It's a bit premature to say with certainty, but it seems that the extent of the bleeding that is shown on the MRI would indicate that she's probably not going to recover to her prior abilities, although frankly the resident doesn't really seem to be familiar with what her previous level of functioning was. But there's no indication of any kind of advanced directives. Actually, Mary would not be competent to have made an advanced directive. And she was placed on a ventilator to maintain her breathing, and the resident is asking the guardian, do you want to execute a do not resuscitate order? Now it's a week later. The guardian wasn't sure what to do and didn't really answer the medical resident's question about the do not resuscitate. And Mary continues to require ventilator support. She's not experienced any other crisis. And now today the medical resident is asking for consent for gastric feeding tube to allow her to receive nutrition. And the guardian has visited Mary 3 times in the past week, but she doesn't even seem to open her eyes when her name is called and when her arm is rubbed. And the staff from the group home that the guardian encountered in the hospital are continuing to say that Mary is going to recover. She just needs some time. So the issues here, if we go on to look at the issues, is the guardian has 2 issues. does he consent to the do not resuscitate in the event that her heart starts beating, or she stops breathing, and should the guardian consent to a gastric tube? So the next thing to do is to really look at framing the issue here. One is identifying the appropriate decision maker. So in this case, there had already been a guardian appointed. It is a guardian, like I described earlier, who does seem to know her as well as possible. He certainly made every attempt to do that. We have to look at certain criteria about is there going to be good for the patient? Are there any broader goods and interests of the patient that need to be considered here? So certainly around the question of do not resuscitate, that when we look at CPR, what is the likelihood that CPR will meet its immediate goal? If the person's prognosis is poor, it might be that no matter what interventions are given, there may not really be any good outcome from that, and there's actually pretty significant literature on the outcomes of CPR initiated in various settings and for different patient populations. But again, a lot of times the portrayal of the success of CPR may influence a guardian's decision. Well, gee, I am the guardian for 2 other people, and they had all of these, interventions done in the intensive care unit, and now they're fine. Instead of really looking at, this individual's, what is happening with Mary. So it certainly would be ethical for the guardian to authorize an order, unless the guardian had some concerns about the accuracy of what the physicians are reporting. But in this case, there really is, there was no question about that. So whether it was allow natural death or do not resuscitate order, whatever is the practice in your area, it certainly would be ethically appropriate for that. The decision about the gastric tube, we really want to be able to, here the guardian needs to try to think about, is the damage from the stroke such that she's really never going to return to her former self? Is the staff from the group home being unrealistic? Are they having difficulty in accepting the medical prognosis? And alternatively, the guardian does need to think about, has the medical team allowed sufficient time to accurately describe the degree of damage secondary to the stroke? In this case, the guardian should really press and ask some more questions of the medical team, and it might even be appropriate to seek a second opinion, and to really, again, look at if Mary is able to return to some previous capacity, looking at the quality of her life. So the ethical question becomes, should the treatment change from stabilizing her function, which is what the team is doing right now, to preparing for comfortable and dignified death? If it's the latter, a decision might be made to then remove her ventilatory support as well. The last point about establishing the healthcare professionals and the guardian's moral and professional obligations, we certainly have an obligation to promote a person's well-being, including a dying process that is dignified and comfortable. If a decision is made to transition to purely palliative goals and to forgo a feeding tube or to remove the ventilatory support, every effort should be made to prepare the person for a comfortable and dignified death, including attention to the caregivers, to their their peace of mind because of the important role that they have played in caring for Mary over the years. In this next slide, again, these are all of the kind of alternative courses to think about, the balance of benefit to harm to Mary. Is there any opportunity for shared decision-making? In this instance, there really is not. In some instances, not in this one in particular, but you may need to take into consideration the norms of family life. You know, again, are we dealing with a group of professionals who have a high degree of integrity? Cost effectiveness is something that is actually frequently talked about in the literature when looking at larger systems. I find, though, with people with developmental disabilities, when I talk with family members about, say, a consideration of going into hospice, it's important to assure the family that the Disability Administration is going to continue to offer support to their family member. This is not about we want this person to go into hospice so we don't have to you know, offer care for them, that they will continue to receive, you know, their full care. And certainly looking at the cultural and religious variation, again, if it's a family member that's making the decision that their family member is no longer really able to participate in shared decision-making, that siblings' religious considerations may really take an awful lot of, take up a lot of space. And then looking at the issues of power, I think this is where sometimes good advocacy comes in. I was involved with a situation a few months ago here in Washington, D.C., and it even every time I relay the story, I catch myself because I can't even believe it happened. A young man in his 30s with cerebral palsy. He was not able to communicate verbally, lived with his mother. Mother took him to one of our university medical centers. He was treated. He was hospitalized for constipation, a common problem of people with cerebral palsy, especially when they are dependent on a wheelchair for mobility. And he was placed in hospice because his mother was told there was nothing more that can be done for him. Certainly that took quite a bit of advocacy to get this young man proper supports. We were up against, you know, a very well-respected medical institution. So these considerations of power, particularly as it relates to people with disabilities, are quite real. And again, as I mentioned earlier, we have to be prepared to critique the decisions that are made. Again, we're not very accurate in sometimes predicting the course of a person's illness or the timing, and so we do have to be prepared to go back to see, you know, did we make the best decision? And even in the event of a person's death, it certainly is important to consider, and sometimes I talk with intensivists about this, who want an answer right away. You know, they want the family to make a decision. You know, we really see this care as futile. We need a do not resuscitate order. And my experience has been over the years is that sometimes people just need a little bit of time. I mean, sometimes 24 to 48 hours for the family member who is making that decision, who's agreeing to the do not resuscitate. It's important for their future comfort to know that they made the best decision that could have been made for their parent, their sibling, their child. So we really do need sometimes some patience, and it's what I call, let's really think about the art of medicine. This is the time that we have to really look at the art of medicine. We also developed a I mentioned a guide that was developed for people to take into care planning meetings. I'm not going to take a lot of time to go into this. I'll be able to show you on our resource sheet where you can see that tool. But in that tool, these 3 points are often very important to be able to relay to the decision maker, because there really are kind of 3 ways to go with care at this point. You know, is it likely, is the care likely to restore and cure the person, or are we only talking about a stabilization? And then if a stabilization requires such aggressive care or such, you know, again, long-term ventilatory support, is it time to prepare the person for a comfortable and dignified death? And I think that if we can frame the person's prognosis in one of these 3 kind of categories, it's often very, very helpful for the decision maker. We also developed a tool, and this is kind of on your screen now, a little short version of it. But looking at the American Bar Association had developed something like this. We got their permission to make some modifications. And you can see in here, if you look at, for example, the second bullet, person can't think or talk clearly. A person with an intellectual disability may never have been able to think or talk clearly. So that may not be a consideration in terms of do they want treatment or not. Someone who has always used a wheelchair for their mobility, again, some type of lack of or loss of mobility in that area may not be such a big deal. The same with controlling bladder and bowels if someone has always had that kind of assistance. The one toward the bottom here of the slide, living permanently in a nursing home, I think is one that may have the biggest consideration. Someone who, even with a significant disability, was used to being around the community, and they're getting out and they're seeing friends and they're going to day program, they're volunteering. If their condition was such that they could no longer be supported in their home, but had to go in a nursing home, that might really be, you know, quite a consideration to think about. Well, maybe it is time to prepare for a dignified death. There was a woman I consulted with last year who her guardian was hell-bent on her continuing her kidney dialysis, and the guardian explained to me this woman needs her dialysis clearly to be able to live. The reason she had a guardian was because she'd had a serious mental illness. But it turns out the woman had already been on dialysis for over 15 years. And it was not clear that she would be considered eligible for a transplant. So, you know, I'd said to the guardian, I think we need to start listening here to what this woman is telling us. 15 years is a very long time to be on dialysis. So again, this isn't the type of thing that is scored. It just kind of helps people, either the person with a disability themselves. I've used this with people who are able to talk and, you know, make their own considerations, and also using it with family members to really help them look at a person's quality of life. This is a screenshot of our webpage that has a lot of additional ethical workup cases that you might find helpful, statutes from the various states. There's a whole list of questions and answers. If a guardian has never been in touch with anyone with a disability, they would learn a lot about people with disabilities, you know, their rights and perspective, and also something about the service systems that are available to support people. And then our last 2 pages, we have a number of different resources that you might find careful. The 2 on the bottom of this screen, People Planning Ahead, is something that can be purchased from the American Association on Intellectual and Developmental Disability bookstore. But actually there's one that is downloadable that is very similar to that, that's downloadable for free, and I think comes in about 2 languages other than English. So I don't know if there are any questions or discussion. Michael, I'll turn the program back to you.
So we do have one question so far, but I also want to remind people that if they have any questions or had any questions that they can remember that they had during the presentation, feel free to ask them now. The question we do have is, in the case of Mary Johns, what happened 4 years ago to request a court-appointed guardian? In other words, what and who initiated the search for a guardian, and how long did that process take?
What I understand from the case study here is that actually Mary had always needed decision-making support, and so she had had a guardian earlier in her life, but guardians change. Sometimes people move, whatever, they get out of the guardian business, and so that often happens over time. So there's often, it wasn't anything that happened to Mary, although there certainly could be a situation where I worked with a team last year who the gentleman had been always making his own decision, and this was part of our critique and looking back after his death. He did not, well, actually his team was beginning to look for someone to help him make decisions in the event he was incapacitated, but he was somebody who was raised in foster care, and they never did find anyone to care for him. And unfortunately, his friends were the people who were his paid staff. So a big part of this push is that, is not so much something that we get involved with maybe in the healthcare profession, but in the broader disability profession. This is why it's so important to help people maintain their community connections so that they can know people, that they can name someone who, in the event I can't make my own medical decisions, I have a friend, George, who's going to make those decisions for me, and you could put together an advance directive, and you don't have to then have, a court-appointed guardian, somebody who doesn't know you at all.
Great, thank you. This is a little bit more of a personal question. They ask, what is it like discussing death or dying directly with a patient who has IDD? Who can communicate with you? So I guess I don't know if you've had those discussions with a patient with an IDD, or you've had it with a patient who does not have an IDD. Maybe what are the differences, and what is the experience like?
Right. Well, I think that when I've had the opportunity to be that person to discuss with the person with an intellectual disability, first of all, I think what we all have in common is that we often avoid that discussion. We don't want to talk about death and dying. We don't want to look at, our mortality. A lot of that is, I think, very much, age dependent, again, culture dependent. So there's some similarities there, but for people with intellectual disabilities who oftentimes think, concretely, may need some visual reminders. Now, I think this next piece helps everyone out. This is something we think about over time, so that it's not just, I don't know, it's kind of like the sex talk, right? You could either get the sex talk one time, whether you need it or not, and then nobody ever talks about it again. Not very useful. And I think it's the same thing with end of life. I think people who experience the normal ebb and flow that we talk about, the family members who die, a housemate who died, we see what happens maybe on the news that shows that people die, that we're not trying to shelter people from hearing bad news. We're not trying to shelter people from experiencing the range of emotions that we have, and that we're sad, and that we may cry. I just did an interview with a woman a few months ago, and it was actually the second time I went to talk with her. The first time, for staff, we were waiting for people to gather, et cetera, and I started talking to Barbara, and finally the staff said, oh, it's time to start the meeting, and Barbara and I had already had most of the conversation, and they said, well, she didn't cry. Usually she cries for us. Well, so sometimes it's helpful to bring in maybe a third party. But again, it's okay if Barbara cries. Barbara has serious kidney disease, and it's not going to get, it's not ever going to get better or go away. And she's already starting, to experience some limitations for that. So, Barbara was able to tell me the things that she really enjoys in life. She told me medical treatment when I explained to her that she thinks she would want, and then she also named some things that she wouldn't want. And I documented that, and we'll probably go back and review again with her to make sure. But at least now, we've had a foundation of a conversation. So I think that people with disabilities have much more capacity in this area. I've heard a self-advocate talk about her own experience with her mother's death, that her family had first thought that somehow they were going to shelter her from it. And she said she was so happy that she was, included in that. So I'm going to speak next month to a group of people, adults with intellectual disabilities, and their service company has invited me to come and talk with them. So I've never done that as a group. I think it'll be really, interesting to kind of, see where the conversation leads us. But I think it's a great opportunity to help them think about advanced directives, naming people and talking with people, thinking about what they would want to do.
Great. That should be very interesting. Here's actually a
I want to put a plug in for a book that has been on the best New York Times, I guess, bestseller list, The Being Mortal by Atul Gawande, Medicine and What Matters in the End. The Georgetown med students were given a copy, first year is a copy of that book this year. And he really gives a wonderful, wonderful perspective about a lot of these, medical decision making at the end of life, which I would really encourage you to read if you haven't picked it up yet.
Yeah, oh, that sounds great. Here's a related question, actually. How can you facilitate discussion of end of life care within the IDD community with both individuals and their families?
Well, here in the district, and it certainly isn't perfect, but it was a start, they actually developed a policy that said every year during the individual service planning meeting, the service coordinators are supposed to bring up end-of-life planning. And then we use the Thinking Ahead book. It's given out to family members, to people with disabilities. And the service coordinator today was telling me she's had the whole range of reaction. She's had people rip it up in front of her. They're horrified that she would bring it up. I would say if I was grading our system, we probably get a B+ for funeral arrangements. We're really good at making funeral arrangements, not so much about what I just spent an hour talking about, really thinking about a person's quality of life. Who do they want to make decisions for? So that's an ongoing process where we're really trying to now target those people when there has been a change in their condition. The capacity that I serve with this DDA Health Initiative project, I'm able to, help remind service coordinators about that. We help to facilitate some of that conversation because we're in touch with the various hospitals here in the community, and the intensivist, Dr. Bullock, who had intended to join us tonight. She's often talking, with the hospitalists, and it's funny, we've kind of made our own observation of the different hospitals and their own cultures about how they deal with these situations, which I think is, to me, it's really, really fascinating. And I think, I think with Medicare, I believe soon is going to have a billing code for end-of-life discussion. Maybe we'll see, the opportunity for physicians to be able to talk about it even in the, in the primary care setting, and not just a discussion that comes up once a person is on the ventilator in the intensive care unit.
Right. Well, I think it's a difficult topic to discuss, and as hard as it is for the families, it's difficult to train someone things like that, because I mean, it's uncomfortable. It's something you don't want to necessarily do, and if you avoid it, then you're gonna run into alternative situations where you, like you said, you don't have the conversation until it's too late, and maybe it's too late to find out what the person might have liked. So actually, here's a question about your lecture. What were the three trajectories, if you can recall them? There's short period of evident decline, prolonged decline, and then what was the third one?
Here we go. The short period, the long-term limitations with intermittent exacerbations and sudden dying, and then prolonged dwindling was the third one.
Great.
Someone who may have recovered from a stroke but had quite a bit of disability, people with dementia, and people who simply, with advanced age may just be having a much slower process with, taking in less nutrition, maybe limited, visual ability, hearing ability, some changes in cognition, etc.
Okay, thank you. We have one more question. You mentioned in the past people with disabilities were denied certain treatments. Have you seen positive change in terms of procedures like organ transplantation? Or is there a bias against people with disabilities based on arguments about quality of life?
There's certainly, even in my career time, has been quite a change. That's part of what is responsible for the longer life expectancy, particularly of people with Down syndrome, who, not only may not have been offered certain cardiac surgeries, some cardiac surgeries techniques didn't even exist. When I was first working in my early career in an institution, there was a young man who had his appendix taken out, and he developed pneumonia, which I think is a fairly common complication of surgery, right? When you write your consent, you say, I realize I may get pneumonia as a result of the surgical procedure. And he was he was offered, and this came from the physicians, again, at a teaching institution in another state, where parents were told, well, we cannot treat maybe we just won't treat the pneumonia. And the parents agreed to it. And I was a young nurse at the time, and I went to this meeting. I knew nothing. I knew nothing about the advocacy systems that really were available to me at that time. But I just went to a meeting and just said, well, how can we do that? This man's perspective, this young man's perspective, is that he was pretty, he seemed pretty content. His parents were bringing up their hurts around that he never drove, and he never went to a prom, and he didn't go to high school. He was pretty significantly disabled, and he was allowed to die from pneumonia, from an appendectomy. So those kind of things I think we don't see, but there was there was a court action taken from the University of Wisconsin hospitals around they actually had kind of developed a bit of a pattern around telling people with disabilities that, they should just go into hospice, they shouldn't receive care, kind of similar to the young man here in DC with the constipation. And then there have been, I think, some other cases of involving University of Pennsylvania and Children's Hospital of Philadelphia around transplant denials. They were and certainly things that the AADMD came forward and really strongly advocated for. So, I think we do still have to be on guard and be careful that, say, a person with an intellectual disability isn't compared to, say, maybe someone who had been able to, be mobile and driving and raising a family and working something very competitive, and then if they all of a sudden, needed someone to care for them 24 hours a day, well then, that would be a big change in my quality of life. But for someone who always has had these supports, and that is their norm, I would argue that we can't say that their quality of life is terribly impacted by that. So I think that we really do have to be careful to try to be objective, to really look at that individual person, and what are their hopes, and what can be done, and as well as recognizing at what point is this situation not going to get better?
Right.
Like the young woman I was talking about who is probably ventilator dependent, and we need to work through a process to help support her family, to help them understand, to ensure that the physicians that are caring for her, who really are going to be the authority figure around this, who can speak with credibility, actually speak about it and don't just kind of, again, not take that on because they don't want to deal with the family. That's a situation where I'm going to push the conversation, in segments, but we're going to get it moving. So.
Right. Great. I'm just going to make a quick announcement, and then there's actually one more question, and then after that, I think we'll be all set. Just to remind everybody about the survey link, I just posted it once again to the chat box. If you could please just follow that link and let us know what you think or thought of this presentation. If you have any comments or constructive criticism or any suggestions, we'd love to hear it. Our last question is, pain management and palliative care is now being talked about more commonly for people in the general population with dementia. This remains a challenge for those with IDD and dementia. How do you see this changing? So I guess
Right. I think we still need a lot of education around this. There are some very good tools available for people who are nonverbal. There are some good, and I can send them to you because it's not going to come right to the top of my head, but some of the pain management associations, there's a nursing association of pain management that have put forth standards that, there are parameters that we can look at other than, whether the person is grimacing or not. But I think that there does need to still be a lot of promotion around that and understanding, what the medication is and what it's used for. I've seen some people who had morphine prescribed because of their breathing difficulties, and the staff wasn't giving them the morphine. These are people in hospice. I'm sure somewhere the hospice workers had explained that the morphine was to help with respiratory comfort. But people think about morphine and they think about pain and may not think about, the ease that it can bring to a person's breathing. So I do think we have some good tools, but it's that application, it's that translation of that knowledge that we do have. And sometimes then again, it really does require that advocacy because all too often people with intellectual disabilities are not able to speak up for themselves, or sometimes even when they are speaking up for themselves, people don't want to listen to them because of their preconceived notions. So it's the continued education, the advocacy, and then the application of what we already know.
Great. Well, thank you very much. I think on behalf of everyone, I'd like to thank you for taking the time out tonight and giving a wonderful presentation. I think it was very informative and on a very important topic. So with that,
you're most welcome.
What's that?
You are most welcome.
Oh, thank you. With that, I think we can say good night, and I hope everybody has a good night.
Good night.